السلام عليكم ورحمة الله وبركاته. أنا الدكتورة مروة سعيد، مدرس طب الأطفال pediatric neurology. Today we are going to talk about headache in children. First of all, we have to ask ourselves if there is headache in children. Is it common? Yes, it's a very common complaint, very common somatic complaint among children and adolescents. But actually we used to see it among older children and among adolescents rather than younger children. It's relatively uncommon before the age of 5 and extremely rare before the age of 3. So we see headache as a major somatic complaint, very common among older children and adolescents. The second question is, how can I reach to the etiology of this headache, or how can I classify the headache? According to the International Headache Society, we have the International Classification of Headache Disorders for the third editions in 2018. These society have classified headaches according to different parameters. First of all, you have the classification according to the onset of the headache. You have an acute headache, which starts acutely as a single episode and it is not recurrent. You have an acute recurrent headache. This is an acute headache which is intermittent while the child is completely free in between. You have chronic progressive headache, so present all the time, it does not go away, and at the same time there is increase in the severity and in the frequency of the attacks of headache. You have chronic non-progressive, so it present all the time, as you can see here, it presents all the time, but the severity or the frequency of the attacks does not increase with time. And of course you have the mixed headache. This is one of the approaches that can be used to identify the underlying etiology. But actually the broader classification and the most commonly used classification by pediatricians is to classify this headache either as primary disease or secondary or others. What is the meaning of primary headache? Primary headache disorder means it means that the headache is the main chief complaint and there is no underlying etiology, while the secondary headache means that there is an underlying etiology beneath this type of headache. The classification or differentiation between primary headache and secondary headache is extremely important because it will help in the management. Of course, in secondary headache the treatment will be treatment of the underlying cause, while primary headache you will have symptomatic treatment directed toward the symptom itself, and that's it. For the other type, this is extremely uncommon type in pediatrics. We don't see it much. Includes the cranial neuralgias, for example, the pain in the herpes zoster infection. This is extremely rare and uncommon, and we are not going into depth in this type of headaches. But what we need to classify between is primary headache and secondary headaches, as we said. According to the International Headache Society, we have 4 main types of primary headache, which is migraine, tension type headache, cluster headache, and others. And as you can see, others is usually as uncommon and is extremely rare. While secondary headaches could be due to very mild causes, for example sinusitis or error of refraction, or it could be through serious intracranial pathology including intracranial hemorrhage, meningitis or other intracranial infections, could be brain tumors, could be increased intracranial pressure. All these pathologies can contribute to headache. And according to the recent classification, now we have what is known as medication overuse headache. The children who use analgesic too much and then they stop the analgesic, they get what's known as rebound headache. And this is a very important terminology we need to keep in mind. The hallmark in the diagnosis of headache is to exclude secondary causes of headaches. This is extremely important. Before you can diagnose and jump into the diagnosis of primary headache disorder, you have to exclude secondary headaches. To exclude secondary headaches, you need to take history, very good. You have to take examination, including neurological examination, of course. And in some cases, you need to order some investigations. The hallmark where you are searching for the secondary causes is to differentiate between benign causes, most probably it is extracranial pathologies, and dangerous and serious causes, which is most probably intracranial pathologies. And this is extremely important to know the red flags, to identify the red flags that donating intracranial pathology. This is extremely important in your management. What I mean by benign causes or extracranial pathology, and actually it is seen very common in pediatric, a child with error of refraction, for example, high myope, and this usually is a school-age child. The headache is usually associated with homeworks or excessive use of screens, and the condition is completely reversible by wearing glasses. Another causes for benign cause of headache, and again it is very common, what is known as sinus tenderness or sinusitis. Headache due to sinusitis is again very common, usually early in the morning, associated with usually have specific distributions around the sinuses, and the child is usually having allergic rhinitis or allergic sinusitis. Pain on chewing, taking this history, headache and pain on chewing, this is not usually seen in pediatrics, including caused by temporomandibular joint malocclusion. This is not usually seen. What is very, very important when we are confronted with any case of headache in children is to measure the blood pressure. This is extremely important. Measuring the blood pressure is vital science, it's a vital step in your examination, in your general examination, especially when we are talking about adolescents, because we have seen cases complaining of headache and turned out to be hypertensive, and we have seen cases that turned out eventually to be post-streptococcal glomerulonephritis, and the mother didn't notice the dark urine, and the child complained of headache for long periods of time before the diagnosis is actually taken. So it's extremely important to exclude these benign causes, since they are very common and they are easily treated. On the other side, when a child or adolescent complained of headache, we have to take care to exclude the dangerous or the serious intracranial pathology. When can I suspect there is an intracranial pathology? Well, there is a specific points in the history taking of headache characteristics that donating an intracranial pathology. Let me go through it, that is extremely important. Number one, the headache is awakening the child from sleep at night. This is very serious and usually donating a space occupying lesion, or it occurs immediately after awaking. If the headache severity is sudden and the worst of his life, sudden and severe, so the sudden onset, the severity of this headache, you should consider intracranial pathology. Of course, if we have an associated neurological symptoms, for example, disturbed level of consciousness, ataxia, history of seizures, of course this is a warning sign. Again, if the headache is changed by changing the position, for example, worsening of the headache from the supine to recampion position, worsening of the headache with a straining, like cough, like during defecation, this might denote increased intracranial pressure. The chronic progressive nature of the headache. Usually the primary headache is acute and recurrent, while the child is completely free in between. While the chronic progressive nature of the headache, no, you should think of intracranial pathology. If you have a specific type or specific quality or specific characteristics of the headache for the child for a few months, and then sudden change in the quality or the severity or the frequency of the headache, once per month, for example, mild to moderate, does not affect daily living activity, and all of a sudden it's a chronic, it's progressive, it's severe, it's very frequent, more than that we used to, you have to consider intracranial pathology. The occipital headache, when the child localizing the headache to the occipital region, this is very unlikely and very uncommon and very worrying, and it should be considered. If I've diagnosed my child to be a primary headache and I prescribed analgesics to control the medication, for example, and he's not responding to any medication whatsoever, so lack of response to therapy is also a worrisome sign. This is about the characteristic or the history taking. What about the examination? Of course, during your examination, you will see if there is an abnormal neurological examination or abnormal focal signs of lateralization, including hemiparesis, ataxia, nystagmus, for example. Of course, if you did signs of meningeal irritation and you said neck stiffness or Brzezinski or Kernig sign, again, this is a worrying that this headache might be due to intracranial infection. If you did general examination and found that multiple cafe au lait patches, for example, or multiple hypomelanotic patches, this is also might donate a neurocutaneous disorder, and looking for intracranial pathology is very important. Regarding the patient history, this is you need to consider that headache in a child less than 3 years of age is extremely uncommon, and it should not go without investigation. So age of 3 is it's very important to exclude intracranial pathology in this child. And lastly, according to the family history, usually in cases of primary headaches, as we are going to say a little bit, we usually have a family history of migraine or family history of headache, first or second relative degree. If we don't have any family history whatsoever, either in the first degree or the second degree, you should consider again your diagnosis of primary headache. Very well. So, according to the headache characteristics, examination, patient characteristics, and family history, you can give an idea that this is a secondary headache due to intracranial pathology or not. But in some cases, you will still need to do investigations like neuroimaging, whether it is CT brain if you suspected, for example, intracranial hemorrhage, or you may ask for MRI brain if you suspected space-occupying lesion or brain tumors. You might need it at this particular point if you find red flags. Again, investigation will not be required if you diagnose the primary headache disorder, or if you don't have red flags for serious intracranial pathology. So that's why you don't need to do imaging for every case of headache. This is not indicated whatsoever. You will do investigations only if you suspected secondary headaches due to and with red flags due to secondary intracranial pathology. If you suspected intracranial infection, you will ask for lumbar puncture. Fundus examination we usually do if we suspected increased intracranial pressure. Either this pressure is increased due to idiopathic, like pseudotumor cerebri, for example, or they increase the pressure due to secondary pathology like brain tumor and whatsoever. Very well. Now we come to the primary headaches. Primary headaches actually constitute the majority of cases of headaches in children, and as I said, it has to become as a diagnosis of exclusion. You have to exclude secondary causes first. For primary headaches, no investigation will be required. No important items of examination, it is only history taking. In order to classify which type of primary headache I'm talking about, you have to take history and a very good history. That's it. There is nothing else will help you in the diagnosis of a primary headache. The three main types of primary headaches, as I said earlier in the presentations, are migraine, as you can see, and there is a tension type headache, and there is a cluster headache. Differentiation between them is usually related to the history taking either from the child or the caregiver. For the tension type of headache, we usually prescribed as band-like squeezing headache, diffuse. There is no specific lateralization, so either unilateral or bilateral. The important features in tension type headache that it does not affect the daily living, that does not affect the activity of the child. The child can still do his homework, can still go to the school, can still watch TV and play with his friends, so it does not interfere with the activity. It is very infrequent, it does not have a specific frequency. Usually it is related to psychological stresses to the child, and that's why we usually see it in adolescents, female, rather than older children, younger children. For the cluster headache, again, we don't see it much in pediatric. It is usually temporal in location or periorbital in location, associated with ipsilateral rhinorrhea or ipsilateral redness of the eye, usually at night. Occurs at night during sleep, and again it is not common and we don't see it much in children. But the most common type of primary headaches, which constitute about 70% of primary headaches, is migraine. This is the most common type ever. Migraine has its own subtypes. The most common, and we see it most often, is the migraine without an aura. What is an aura? I think you have heard about the aura before when we're talking about seizures and epilepsy. The aura is the signs and symptoms that occurs immediately before the onset of the headache. So we have migraine without aura, and this is actually very common, constitute about 90% of cases of migraine. And we have a migraine with aura, and this is about 10% of the cases. This is the most common and the most commonly seen in pediatric. You have an uncommon types of migraine. For example, hemiplegic migraine. This type of migraine is the headache is usually associated with hemiparesis or even hemiplegia. During the attack of migraine may last for a few hours or up to a few days, 72 hours for example. It could be sporadic and it could be familiar with positive family history. Again, you have what is known as basilar type of migraine, associated with brainstem-like manifestation, disturbed consciousness, confusion, abnormal involuntary movements. They call it Alice in Wonderland. And you have chronic migraine, as we said in the according to the pattern. Migraine is usually acute, recurrent, while the child is completely free in between. But there is an uncommon variant of migraine when it is chronic, but is usually non-progressive. And lastly, extremely rare, we have what is known as episodic syndromes. Episodic syndromes, these syndromes is usually associated with migraine, and the underlying pathophysiology and the treatment actually is like migraine. For example, I will give you an example: cyclic vomiting. Cyclic vomiting, this child usually complains of every 3 weeks, for example, every 3 weeks the child goes into an episodes of severe vomiting. Sometimes it necessitates going into severe dehydration, and sometimes it needs intravenous fluids even. For a few days, lasting for 3 to 5 days, and then the child go back to normal and it is completely free in between, and so on. This is recurrence. It is not necessary to be at a regular interval. It could be every month, every 2 months, or it could be at regular interval. This is one of the episodic syndromes that might be associated with headaches. We are going to talk about the most common type of migraine, which is migraine without aura. This is actually the most common. As I said before, to diagnose migraine without aura, it's all about history taking. You have diagnostic criteria and you have to fulfill these diagnostic criteria. Number one, at least you must have 5 attacks. You cannot diagnose migraine from the first attack or from the second attack. So you must have 5 attacks that fulfill the diagnostic criteria beneath. Number 2, the headache lasts for 4 hours to 72 hours. And actually in pediatrics, the headache can last for 1 or 2 hours. Not necessary to last for 4 hours to diagnose migraine. In pediatric, it could be only 1 or 2 hours. Of course, I'm talking about the attack which is not treated. I didn't give any treatments to support the attack. So the headaches that last for 5 minutes or 10 minutes and goes away, it's not migraine. The headaches that last for a week and does not go away, it is not migraine, a typical migraine at least. And then this headache must have 2 out of 4 characteristics, which is unilateral location. Okay, the unilaterality, which is very pathognomonic, and the characteristics for headache migraine, it is usually not seen in pediatric. In children and even in adolescents, the migraine headache is usually bilateral, and we don't see unilaterality very often in children. It's pulsating in nature, throbbing or pulsating in nature. This is very important, and the older the child, he can prescribe it very well for you. Number 3, the pain for migraine is moderate or severe in intensity. And this is actually very important because as you remember, when I was talking about tension type of headache, I said the headache is usually mild and does not interfere with daily activity. No. The headache of migraine is usually moderate to severe. The child leaves everything he's doing, even if he was playing, for example, he leaves everything because the intensity of the headache is severe or moderate. Number 4, it is to be associated or aggravated by a number of aggravating factors. As I said, for tension type of headache, it is usually aggravated by psychological stress. No, usually the migraine is aggravated by physical stress, like walking or running or exposure to sun or something like this. If you have 2 out of 4 these characteristics, so you have one of the diagnostic criteria. And number D, during the attack of headache, the child must have at least one of the following. He would have associated nausea or vomiting, photophobia, cannot difficulty in seeing in the light. He just wants the light to turn off. Or phonophobia, he doesn't want to hear any sounds surrounding him. He just wants to stay in a quiet room, and that's it, with a quite dark room. And this is actually one of the line of treatment. So if you have at least one of these manifestations associated with the attacks of headache, this is crucially important for the diagnosis of migraine. And here you will have what we have been talking about earlier. It is not better accounted for by any other diagnosis. I mean that we have excluded secondary causes. I have excluded the benign extracranial pathologies and the serious intracranial pathology. So to diagnose migraine without aura, you must have all the 5 criteria. The second type, as I said, which is not so common, the migraine without aura, and as you can see here, this is a pre-momentary, pre-headache stage, where the signs and symptoms occur before the onset of the headache, and then we have the headache, the outburst of headache, which is again is stages, mild, moderate, up to the severe, and following by post-headache or post-ROM of either confusion or sleep and whatsoever. You get your diagnostic criteria for the migraine with typical aura. What I need to know that the aura in children with migraine is usually either visual aura, like for example scotoma, or seeing line in the air or something like this. Could be sensory, like numbness or tingling sensation. It could be dysarthria, it's responding with extreme difficulty. However, it is never motor, never to be considered as an aura. Any motor presentation that occurs preceding or during the attack of headache is not considered to be an aura. We have to think of other uncommon types, for example, basilar type of migraine or hemiplegic, for example, but the aura is never motor. This is number 1. Number 2, the aura is fully reversible. So I can't have an aura of, for example, dysarthria, and then I have the attack of headache, and then the dysarthria persists for a few hours or few days. No, the aura is fully reversible. This is considered as migraine with typical aura. Otherwise, I should think about the uncommon forms of migraine. I'm not going to talk about the pathophysiology and the exact etiology of migraine because it is very complicated and the exact etiology is still unknown, and there is a lot of theories including the neurotransmitters and the channelopathies and the neuronal pathways. But let us be clear that we have underlying genetic causes, and that's why we see migraines in the first degree relatives and the second degree relatives. Post-family history is not one of the diagnostic criteria, but it is extremely important, as I said before, that lacking of post-family history is a worrying sign for me. So it has its underlying genetic causes, but we have an aggravating factors usually, and this is one of the diagnostic criteria of migraine. This aggravating factor could be the stress in the daily life activity, very mild inflammations. It could be the estrogen, and that's why we see it a lot in females at the menarche, affecting the neuronal activity by some way, by vascular mechanism, vasoconstriction and vasodilatation of intracerebral blood vessels, causing the clinical picture of migraine. If I diagnose the migraine, should I need to do imaging? Again, as I said before, imaging is not required unless I suspected secondary intracranial pathologies and the red flags were there. So, when can I ask for an imaging in a case of migraine, diagnosed as a migraine? You have a specific indications. If you diagnose your child as a migraine, you can still have to ask for neuroimaging. Of course, if there is an associated focal neurological manifestation, this is of course. If you have a migraine with atypical aura, of course. If you have the uncommon form of migraine, like as I said, seizures, for example, or hemiplegic migraine or basilar type of migraine, you cannot diagnose these uncommon forms without doing a neuroimaging. But I need you to look for here that headache in children younger than the age of 6 years old It's very worrisome to prescribe this headache as migraine, because the child will not be able to describe the pain, the headache characteristics very well. So it is better to do neuroimaging if your child is less than 6. And lastly, if you doesn't have an obvious family history of migraine or migraine variants, as I said, that's the uncommon types of migraine. So at this point, I think you should do neuroimaging, and this is what is indicated for in the guidelines. For secondary migraines, as we said, you have to treat the underlying cause. But here in migraine, you don't have an underlying pathology, so you are going into symptomatic treatment. You are dealing with the headache itself. You have 3 main blocks of treatment. You have an acute or rescue treatment, and these are the medications and the non-pharmacological measures that I am taking for the child to abort the attack, attack of headache or attack of pain. And we have what is known as prophylactic medications. These are medications given to prevent the occurrence of the headache. You have a certain indications to prescribe prophylactic medication. Not every child with migraine will need prophylactic treatment. When I need prophylactic treatment, if your headache is very frequent, more than once per week, if your headache is very severe, we have the severity scales, so we have very severe headache that makes the child missing a lot of days at school days, making the child has a deterioration in his academic performance, for example. So the increased frequency and the severity is one of the indications for prophylactic treatment. And again, we have some sort of psychosocial supports that we are going to talk about. The acute rescue treatment, the most common is the analgesic treatment. We have paracetamols, we have other non-steroidal anti-inflammatory drugs like ibuprofen, for example. The key point in these analgesics that you have to give the analgesic to your child as soon as possible, very early during the attack. I'm talking about the first 30 minutes of the attack, after which the analgesic usually will not be very effective. You have an antiemetics. As you can remember, we said that nausea and vomiting might be the associated factor with migraine, so we can give an antiemetic for this nausea. Serotonin agonist like triptan is one of the FDA approved medication for adolescents. Again, during the acute rescue treatment, you can put the child in a quiet, dark room with a cold compresses. This will make the headache goes away much faster. The prophylactic treatment, we have lots of medication. We have calcium channel blockers like flunarizine. We have tricyclic antidepressant like amitriptyline. By the way, this is the most commonly used, again, in adolescents. We don't have an FDA approved in children yet. We can use anti-epileptic medication even as a prophylactic treatment for headache. The most commonly used is topiramate and sodium valproate as sodium channel blockers. Even propranolol as beta blocker, one of the prophylactic treatment. As you can see, you have different mechanism of action because you have different pathogenesis for migraine. So these drugs have different mechanism of action. What I mean of psychosocial support, I mean to relieve the aggravating factor, for example, to relieve the psychological stress if I'm talking about adolescents female, of course to teach the child or the adolescent's relaxation technique that he might do during the attack, and of course to donate a healthy lifestyle, good sleep time, healthy foods, a lot of water, lack of exposure to the sun, and so on. These are very important, again, as a part of treatments for migraine, healthy lifestyle to reduce, especially in children who have very frequent migraine. To sum up, headache is common in pediatric. It is either primary headache or secondary headache. Secondary headache, you have to exclude it first, and you might need investigation to do this only if you have red flags. Otherwise, if you diagnose your child to be primary headache, you only have history taking to diagnose the underlying etiology. Let's summarize what we have taken. If you have an acute headache, so think about secondary causes, whether it is benign or not. If you have an acute recurrent headache, think about primary headaches. For example, the most common is migraine. If you have chronic and non-progressive headache, think about other psychological types or tension type of headache. But if you have chronic progressive, keep in mind that space occupying lesion and secondary causes is extremely important. I think I gave you headaches, so thank you so much.